did progress the cells of cancer patients through the cycle, that is from G0, G1, from the quiescent phase to the G2S phase of the cell cycle. In other words, that meant that there was a reactivation of the normal immune reaction mechanism in these cells, only in the lymphocytes of the cancer patients. And this was documented numerically. Here you can see that by adding alpha-lipoic acid, N-acetylcysteine, and amifostine, you can see that in normal patients there was not a significant increase in the S-phase cells, whereas in the tumor patients there was an increase from 132 to 150 to 140%. And that means that in this case the antioxidants were indeed able to induce a restoration of immune efficiency as we interpreted it in these patients. Next, we looked at an in vivo study in humans, in patients with cancer, and we wanted to see whether treating these patients with antioxidants, and we'll see which ones in a minute, they were divided into 5 treatment arms, whether antioxidant treatment could actually show an improvement in the oxidative stress and also the other aspects in these patients. These are what we looked at. This was the aim of the study. And these are the patients, 56 patients with cancer in various organs and various stages and different performance statuses. We assigned them to 5 treatment arms, 5 different treatments. And these are the arms: alpha-lipoic acid, 200 milligrams per day, N-acetylcysteine, 1,800 milligrams a day, or carbocysteine lysine, all taken orally. Amifostine, IV. Amifostine was an antioxidant used at the time, particularly for damage induced by ionizing radiation, and today it's far less used, a little bit in radiotherapy. Reduced glutathione, IV, and vitamins A, E, and C given orally. The treatment period was 10 days, and the first 28 patients were given were in one arm. Then 28 patients were given treatment where in each arm at least 2 antioxidant treatments were combined to see whether combinations were any better in increasing the efficacy of treatment. And you can see that we've combined them fairly randomly, but we did try to ensure that the treatment was all oral, so that the patients could take the treatment at home, versus the IV treatments that required the patient to come to a clinic for the treatment. The patients were treated for 10 days. We then looked at the results, which were assessed in terms of ROS levels and peroxidase glutathione. There was a decrease in ROS and an increase in GPX, both significant, a decrease in IL-6 and a decrease also in TNF-alpha. Now, this was independent of the status of the disease, the stage of the disease, and the ECOG and performance status of the patient. So these results were found in patients with 0-1 performance status and with 2 or 3 performance status. Please, I'd like the moderators to let me know when I'm getting close to the end of my time. This obviously led us to conduct another study combining the oxidative stress treatment with cachexia treatment to see what could be achieved in terms of effectiveness. And we conducted a phase 2 trial for the treatment of cachexia and oxidative stress. We wished to assess a number of parameters: clinical response, improvement of nutritional and functional variables, changes to laboratory variables, and improvement in the quality of life. The ultimate goal of the study was to transfer the results, hopefully positive and potentially positive, of our study from patients with advanced cancer to patients in precancerous stages, to see whether it was possible to prevent the onset of cachexia by giving these treatments at an earlier phase when the cachexia has not yet appeared or is not detectable clinically. And that was the goal of the study, because as we'll see later, the application of the treatments, once cachexia has appeared and unfortunately is almost irreversible, well, the results may be at best transient and certainly not long-lasting. We conducted a phase 2 trial. We introduced 39 patients into the trial. The eligibility criteria were very extensive. There was no age cutoff between 18 and 80 years. Histologically confirmed tumors of any site. Patients had to have lost at least 5% of their body weight in the last 3 months and or have high levels of cytokines, ROS, predictive in this case of the onset of cachexia, which had not yet appeared. The patients were treated either also with antineoplastic treatment, and the treatment was for 4 months. One of the eligibility criteria was a life expectancy in excess of 4 months. We also included patients who were not strictly terminal, but who still had a life expectancy. So there were no exclusion criteria other than those which might have significantly changed diet, and our treatment was primarily based on diet and on the uptake of support, oral support. So we excluded patients with head and neck injuries, preventing normal eating. So we had to decide on a single treatment to see